Welcome, everybody. I think I know everybody here. I'm Tom Chandler. I'm Dean of the Arnold School. Thanks for coming out. This is our fourth lecture series on childhood obesity. We do 4 major lectures over the course of the year. We do this one. We do one on healthy aging. We do the Wernberg lecture every year, which is on a topic that varies really depending on who we can get to come to Columbia, South Carolina. And then we do the Clyburn lecture later in the spring. This year we'll probably do a Delta Omega lecture as well. We're still working on a speaker, not to lecture everybody out, but thank you all for coming. This is a good turnout for Deanna. And thank you, Deanna, for visiting with us. We're all excited to hear what you're doing at UT Austin Health Science Center. Is that what you call it? Just UTHealth. Deanna's the regional dean at UTHealth in Austin, and she works on a subject very near and dear to all of you in the room. We're quite proud of what we do in the Arnold School in physical activity and health, linkages with physical activity, nutrition, and particularly in children and adolescent health. I've seen the 2019 Women in Health report for South Carolina. We actually moved up in the right direction in the rankings this year. I think we went from 42 to 40th worst in childhood obesity. I've been in public health now for 32 years, and I think when I came here we were at 44th or 45th. So we're making some progress. What bothered me in that report is that if you look at, and I'm sure you have similar issues in Texas, if you look particularly at neighborhood amenities, access to parks and recreation and playgrounds for children, we've actually slipped to 47th worst in the country. So there's a lot of work to be done, particularly in the built environment, to get kids and adolescents moving, and I'm sure you'll touch on that sort of thing, but something we're interested in as well. So thank you for coming. Michael is going to come up and say a few things about you and your career, and then we'll look forward to your talk. So thank you.
Thank you, everyone, for attending our 4th annual Norman and Gerry Sue Arnold Childhood Obesity Lecture. I believe it was probably about 5 years ago that the dean came to me and he said, what could you do with about $300,000 a year? Could you give me like a big timeline and stuff? And so I gave him all this fancy stuff of accomplishments, milestones and everything. And then he turned it around and said, well, what could you do with about a tenth of that? Could you do the same amount? And I said, I can, Tommy. I can deliver on that. And so, but I thank you all that I'm very excited that we're here at the 4th annual one. And before I introduce today's speaker, as you will notice, for some of you that are returning to have been here with us from the 1st, 2nd, and 3rd, that we're doing something different where we're trying to highlight the great work that's going on with our graduate students in their Arnold School of Public Health around their work related to childhood obesity. So we have a poster session. And so I thank those of you that came early and either viewed or had a chance to speak to our poster presenters. Their posters will be up throughout the duration of this and will stay up until 5 o'clock when the venue is up. But also you'll know that as part of our lecture series, we award 2 recipients within the Arnold School for the Emerging Scholars in Childhood Obesity Graduate Scholarship Award. And this award is done to recognize outstanding current and future prospective colleagues in the area of childhood obesity. And what we'll be doing differently this year is that we'll be announcing the awards after our lecture, and then giving them, our 2 awardees, an opportunity to stand up here for 10 minutes or so and give them an overview, allow to give an overview of their work that they were awarded for. So we'll be doing that at convening our lecture talk today. So speaking of that, it is an honor and a privilege to have our speaker here today, Dr. Deanna Hoelscher. I would read off a lot of her accolades, but I had her vita printed off, and this is actually double-sided. If any of you remember the old phone books, you know, little feat of strength, I don't think I can even tear it in half. I'll just share some of the highlights about Deanna that I've taken from her 80-something page CV. So she is the Regional Dean of Research at the University of Texas Health Science Center at Houston, UTHealth, School of Public Health in Austin, is that correct? And the Director of the Michael and Susan Dell Center for Healthy Living. She's had a very impressive career over the last 30 years. She's been a leader in school-based interventions surrounding physical activity and health, which I know her from, and also more so recently with sun safety and e-cigarettes. Her work includes such highlights as position statements for the American Dietetic Association for interventions on the prevention and treatment of pediatric overweight and obesity. And although I've really only known Deanna since this morning, one thing that I love about our field is that we get to really know people from the work that they produce. And so I feel like I've known Deanna since the late 90s when I was first exposed to her work as a master's student at Wichita State University, where I started reading her work related to school-based physical activity and healthy eating interventions for kids. And so I'm very excited to have you here to speak to us today, so please help me welcome our speaker, Dr. Deanna Hoelscher.
Thank you all. It's very exciting to be here. I love the weather. It's so much nicer than in Texas right now. And I just really appreciate the chance to come and talk to people. I basically want to collaborate with a lot of you, so hopefully we'll keep the conversation going after I get back home to Austin. So most of my research is in Texas. And most of it comes out of the Michael and Susan Dell Center for Healthy Living. So our vision is healthy children in a healthy world, and we do this through groundbreaking research, innovative community-based programs, and dissemination of evidence-based practices. So I'll talk a little bit more about what we're doing now with the center. But before I start talking about Texas, I thought I'd talk about South Carolina too. So in our family, we look up facts. So we're a big facts family. So we're always trying to outdo one another with a fact. So I found facts about South Carolina and Texas. So South Carolina has the palmetto as their state tree, and y'all are the palmetto state, right? I got that right? Okay, good. We have a pecan tree. So palmetto actually sounds a little bit more exotic, I think. But I had to say this so you'll see why in a little bit. So y'all state dance, you get a lot of physical activity doing the South Carolina shag, which I don't know how people move their feet on that. I was looking at some YouTube videos and it's a little bit amazing. Anyway, they said learn how to do it in like 5 minutes. It was like, no way. Texas, it's the Texas two-step, so a lot easier to do. Y'all's state battle is the Battle of Sullivan's Island. And I thought it was really interesting. There's a picture of it because the fort apparently was built with those palmetto trees and the cannonballs bounced off of it. And that was the first Revolutionary War battle, right? Won in the United States, I think. So anyway, very famous battle. Ours is the Alamo, did not end as well. So I found out y'all have a state monster, Messi, at Murray Lake. And there's a picture of Messi. So I don't know if it's really a giant eel like Nessie is, but I thought it was interesting reading about people who've run into it. Our state monster's the chupacabra, and there it is. I think it's really just a skinny coyote, if you ask me, but apparently they've got one stuffed somewhere. So I also found out that y'all have the peach capital of the world, and there's even peaches on the carpet in the hotel. Well, I'm from Floresville, Texas, which is the peanut capital of the world, although unfortunately I'm allergic to peanuts. But my one last nutrition bit about South Carolina. So does anyone know what the nickname for South Carolina was before the Palmetto State? It was the iodine state. And so there was a big like PR campaign in the 1920s to tell people to eat their fruits and vegetables for the iodine content, because the soil, I guess, is very high in iodine here, and to drink milk. But my favorite story about that, but then what happened is iodized salt came out, so that kind of like ruined the iodine state for South Carolina. However, they did say that the moonshiners even got into the act, and their kind of catchphrase for that was moonshine, not a goiter in a gallon. So anyway, my little nutrition history, my nutrition fact from South Carolina. I thought that was so cute. I like that. So I'm going to talk about 5 questions today and answering them during my presentation. So first off, just a little bit, I know y'all know about child obesity, so I'm going to talk about why we study it in Texas and a little bit about the demographics of Texas. I'll talk about our trends with some recent data we have, how we can address child obesity at the population level, how we've done it with primary care public health partnerships, and then finally about policy and some of our newer work. So one of the things with Texas is that demographics very much mirror what we think the U.S. is going to look like. So we're very diverse, a little bit lower income than the rest of the United States. But Texas is very big, as y'all know. The most recent census estimates are almost 29 million, which when I presented this in Europe, I think the European countries are kind of amazed how big it is. But really the statistic that matters the most to me is 1 out of every 10 kids in the United States lives in Texas. So if you influence Texas, you'll influence a significant amount of the United States. We're also young. Our average age, our median age is younger, and very diverse, as y'all know, specifically Hispanic populations, and our border with Mexico. So I'm going to start off by showing you some data we have on child obesity in Texas using our Texas School Physical Activity and Nutrition, our Texas S.P.A.N.P.A survey. So we objectively measure height and weight for students in 2nd, 4th, 8th, and 11th grade. We also give them a self-administered questionnaire for the older kids, and then a take-home survey for parents of 2nd graders. And so we ask a lot about nutrition, physical activity, sleep. We've asked about some different parameters. So we do a multi-stage probability-based survey so that we get a representative sample. And we're representative at the state level, also at regions around the state, and then border versus non-border. So this gives an idea. The last time we did SPAN was in 2015 and 2016. So we surveyed a total of 17,000 kids over it was about a year and a half. They represent about 1.3 million kids. In Texas, we've got about 5 million. These are the public school kids that they're representative of. And as you can see, those are the numbers for each of the grade levels, the number of districts and the schools surveyed. Just to put this in perspective, when NHANES does their panels every 2 years, for the kids, the total kid population is about 3,500. So we're kind of on par with that with some of our sample. So just to show you our diversity, we have a significant Asian population. We haven't really oversampled them yet, so we've kind of stuck to 3 racial ethnic groups in Texas, although we're more varied than that. But as you can see, we're a majority Latinx population in all grade levels right now. So this was in 2015, 2016. It's gotten a little bit, it's increased a little bit more since then. We have a significant African American population, which kind of mirrors what it is in the United States. So these are the trends in child obesity in Texas, and so this was from 2000 to 2016. So if you look, 4th grade, we started up almost 26. We decreased in these 2 years. There were a lot of policies passed. I'll talk more about that later. But then we saw it jump up. And that's a statistically significant quadratic trend, which is not really what we want to see, where it dips and then goes back up. This is the 8th grade data where it goes up, and the 11th grade data also goes up, but these were not statistically significant. So when you look at this, this is the current US data. So for kids that are 2 through 19, and you can see that we're well above that for all grade levels. And then this is Healthy People 2020 goal. So we're really way above that. So we've really got an issue in Texas, and it's getting a little bit worse. So I can tell you more about that as we go on. This is the slide that really hits it home to me as well. So this is looking at severe obesity, which is 120% of the 95th percentile. And so NHANES has just recently started to add this. And if you look in 2nd, 4th, 8th, and 11th, this is our data, this is the US. So we're almost twice as much, especially for the younger kids. And since we know that obesity tracks over time, that's a worrisome trend for us to see. So the other thing we look at is border, non-border data, and we've actually got some kind of interesting data there. So here there are 32 contiguous counties that, with the La Paz agreement, are our border counties. And so we actually weighted them separately than the rest of Texas. And one of the things we found is that in all cases, the absolute percentage of obesity is greater on the border. It's only statistically significant at the 11th grade level. So these kind of show our adjusted odds ratio. So you can see where the children with obesity, where it's higher. And so if you look at it here, girls tend to be less obese than boys. We do see some racial ethnic groups. So we used 2 models here. In this model, we used our statewide estimates. Here we used our border estimates. So if you look with Hispanic Latino kids, they are higher odds of having obesity. African American kids, if you look at the border weights, they have higher odds. This is something that changed from last time we did it, is there's no difference between the grade levels. And it used to be that 4th was higher than 8th and 11th. So that's a little bit alarming to us too, that there aren't differences between them. But what you really see, is, I keep hitting the wrong thing, is the percent economically disadvantaged. So that, of everything, you see the strongest odds with that. The other thing is if you look border versus non-border in a adjusted model, there's no differences. So it's all over the state. You can't really point to the border specifically. So kind of in conclusions, as you can see, we have significant health disparities in child obesity rates by economic status, border status, just for the 11th graders, and then race, ethnicity. The other data I didn't show you from SPAN is the kids do not consume at least 5 fruits and vegetables a day, so low fruit and vegetable consumption. They don't engage in adequate physical activity. A lot of them have devices. With the internet, even in their bedroom. And it seems to change between 2nd and 4th grade, is what we've seen. The data at the regional level have actually been very useful, and you'll see some of that in a little bit. And it takes a long time to get into schools. So we did a process data. So y'all work in schools a lot. We did some process data to look at the time you first contacted the school to when they let you in, when they gave you the approval and said you can go. And it ranged from 0 to 422 days. So we're really trying to get that published because we think that that will help us in the NIH grant game when you ask for that year or 2 of lead-in time to kind of establish those relationships. Then once you get in, it can take as many as 400 additional days once you get the approval. So it's really it's really variable and a lot of time. And just real quick, wanted to show you my team. There's a lot of different people here. And one of the things about SPAN is we partner with people all over the state with different area health education centers, the Office of Border Health, lots of different people do practica with this. So we've got kind of a distributed data collection for that. Okay, so now I've shown you kind of the bad news. So what's the good news? What can we do? So we do know that we have some programs that work, that we can always make better though. So this is from the Accelerating Progress in Obesity Prevention report that came out of Institute of Medicine, now NASM, a few years back in 2012. And if you look at this, one of the chapters, my favorite chapter, is Strengthen Schools as the Heart of Health. So that's where we focused a lot of our work. So a lot of the work I've been involved with is coordinated approach to child health. So we've used that in a lot of our different studies. We've done a lot of different testing. Some of these programs have been more rigorously tested than others, so I'll talk a little bit about those. Although now we're switching to the WISC model. So we're really using that in more of our work to be consistent with CDC. So in the original study, I think a lot of people don't realize in the original catch, we were actually told not to have the kids lose weight because at the time it started in the 90s, they thought that we would affect their growth if we decreased their caloric intake. Because remember, in the 90s, the child obesity epidemic was non-existent. So at that time, as a nutritionist on catch, they actually made us go back and alter some of the diet to say don't focus, because originally we had said like fruit packed in water, for example, and they said no, you could do light syrup, so you need to add a few extra calories. So it's incredible now thinking about it, but at that time that was the common thought of the day, is you would affect their growth trajectories, which we know now is not the case. We have changed that since. We did get some outcomes on obesity, but they tended to be more racial ethnic oriented when you looked at it by groups. But we've done some replication studies with Texas, and so the one that's most interesting is El Paso. And this is actually our F.I.S.B.N.P.A data. So another group went in and did an implementation of catch. And so they did a really great job because they went through the educational service centers and they did catch. It was like everywhere in the schools, and then they went to the community. So you'd go to Barnes and Noble and there would be a catch lesson going on. And you would go into like school libraries and all these different places. So they were really out in the community quite a bit. At the same time, they did some other programming. So after that 8-year, we kind of measured them on both ends of this initiative, and what we found is a 7% decrease in obesity in 4th graders. And so that was in the El Paso area, and the area we're looking at is really a region the size of South Dakota and Wyoming combined. So it's a very large area that we saw this decrease. And it's one of the first documented decreases in children with obesity. We also did a Travis County replication study. It was more of a demonstration study, and we implemented a community component to it. And what we found is a reduction of 8% in our catch community schools compared. This is in the prevalence of children with overweight and obesity. And the student outcomes were also better in the schools, in the catch schools that implemented fully. And I'll talk about that in just a second. So we've been looking at implementation a lot lately, and I know I was talking to Nathan about this, no, I was talking to Glenn about this, about the implementation. So what we found is the implementations led to better outcomes in our Travis County catch trial. So what we did was we took our schools in our Travis County. We had 3 conditions. So we had a basic condition that was just catch materials. We had a basic plus that got training and support. And then the last was basic plus community. And we got training plus support plus we had a community component. So they had to bring the community into the school. So usually we did this through catch committees. And then we took all of the schools. For this study here, we looked across all 3, so we didn't do it by group, but we looked at how well they implemented over the 4 years of the study. So spring '07 was before we went into the schools, and then we did it every subsequent spring. So when you looked at the lowest quintile, what you found is they kind of stayed the same. You saw a slow uptick, but it wasn't statistically significant. The middle 60% were about the same. But the highest quintile, we actually saw this decrease. So it was significant for this year, the second year, but not the third year. It kind of ticked up. But this was really interesting to us because several factors were associated with implementation, and these were the factors that were associated with implementation. So they had to do with, they had weekday themed events, so Fresh Fruit Friday. So every Friday, kids had to bring a piece of fresh fruit. It's kind of interesting because sometimes the kids would cry if they didn't have a piece of fresh fruit. So the cafeteria had to keep a stock in case a kid forgot their fresh fruit for the day. Participation in one or more of the 5 named catch activities, the number of morning announcements, and the extent to which the catch activities were coordinated. So we think that coordination function is an accountability, because even though you're required to do coordinated school health in Texas, there's no accountability. So if you don't do it, nothing happens to your school district. With the classroom activities, it was the number of lessons taught, whether teachers coordinated, and then students reporting whether or not they did it. With parent communication, it's the catch materials sent home. And then in the cafeteria, we looked at good meal practices, but also promotional activities. So a lot of these were promotional and coordination activities that we found associated with better implementation. So now I'm going to talk a little bit about policy and how policy figured out in this. So this was our span. This is what I was talking about our map. So it's not at the county level. Darn, I wish it was at the county level. But it's by regions. So this is how we measure. We do it by regions. And if you look here, the darker it is, the higher the prevalence of child obesity. So here, right around here, it was above 35%. This was 25% all around here, so closer to the border and in Houston. And then the rest of the state was 20 to 24.9%. So as you can see, very high prevalence of obesity. So then when we went back and measured, and these were the data I was talking about, you can see in El Paso we had a decrease in the obesity rates, which I mentioned before. And so what happened in the meantime, PNDF is the Paso del Norte Foundation. So this foundation came in and said, we want to do something for child obesity. So they funded CATCH. They also funded a program called Que Sabrosa Vida, which was a cooking program for mothers and grandmothers. And then they funded Walk El Paso, and they funded this media campaign. So it was very Hispanic in origin. It talked about food as celebration. It was on radio and TV. At that same time, we had some significant legislation that put into place our coordinated school health program. And then the Texas Public School Nutrition Policy was implemented. So this was before Healthy Hunger Free Kids Act. So a lot of things happened in the years between these two. Then when we came around in 2009, 2011, the prevalence of obesity went back up. So what happened in that time? We had a little bit more legislation, but the Paso del Norte Foundation decreased their funding for the programs. So they removed their funding. So what this showed us is not only do you need policies, but the policies need to be funded, and they need to be able to be implemented fully. So a few of the implications is you need to implement evidence-based programs. The implementation is important. So we're really looking at implementation science for a lot of what we're doing, and dose. Dose is very important. Policies can help with program implementation dissemination, but it's difficult to maintain implementation over time. So that's really kind of the nut we have to crack, is how do we keep this going after a while? Do we need to change it over time? Do we need to switch up programs? And then just a few acknowledgments. A lot of funding for this work started at NIH and then expanded to a lot of foundations. So now we're going to switch to primary care and public health. So a few years ago, we got a grant from CDC. It was a demonstration grant, again, trying to link primary care and public health. So really finding out if you go into the clinics and get the kids and then combine them with public health programs in the community, do you see better outcomes? So this was our cord project, and we did it framed within primary prevention versus secondary prevention. So primary prevention is we're targeting the whole community. We target kids at a healthy weight. We look at prevention of child obesity, and we look at environmental and programmatic changes. With secondary prevention, you're looking at children with overweight and obesity, and we're looking at preventing the disease from getting worse and more intensive programs. So our Texas Cord study aims were to implement and evaluate a primary prevention program. So we were looking at the primary prevention program. We were also looking at a 12-month family-based secondary prevention program, and then we were going to look at cost effectiveness of the program. So this was our study design. So we were working in elementary schools, child care centers, and in primary care clinics. So from the primary care clinic, there was a referral to our secondary prevention program. And I'll talk more about that, but it involved YMCAs, community health workers, and then we had community organizations as well. And then we did some government and public policy work. So to show you, this study was conducted in both Austin and Houston. And so in each area, we had an intervention community and we had a comparison community. And if you look at them, we had 3 age groups we were targeting because we wanted to look at kids in terms of developmental levels. So here was Head Start, then we had 2nd grade, and then we had 5th grade. So those were our 3 age groups. And if you look here, you can kind of see what the prevalence of obesity was in those areas. So it's very high, especially in the 5th grade where you had 56% of the kids having overweight or obesity. So just a little bit about our primary prevention. We did CATCH early care and education. So there's the CATCH ECE box. So this is a real fun program, very developmentally appropriate. The physical activity part is kind of fun because they have ribbons and they do dances and there's music associated with it. So it's a lot more fun than our elementary school program, and the kids like it. So what we did was we looked at our intervention and control Head Start. So we had different number of intervention and control kids, child care centers, and these were the outcomes that we were looking at. So in looking at the outcomes, this is Shrila Sharma, who's developed a lot of our preschool programs, and Courtney Bird-Williams and Lindy Chang. And what we found is a decrease in child BMI Z-score and percentiles following 2 years of implementation. So we really kind of found what we wanted in the Head Start. You know, you always like for it to be more than a modest change, but at least we saw some changes there. We did see some near significant changes in some of the dietary variables. We didn't see changes in the physical activity or sedentary variables. For this study, we just used survey data. So we didn't have very precise measures, mainly because we were spread so thin in so many places. We didn't see any differences by racial ethnic group, but we did see a high implementation of the program. So they really loved the program quite a bit. So at the same time we were doing this, we were acting in the schools. And so with the schools, we did CATCH. And so we were really focused on those CATCH committees that I had mentioned before. And then our measures were pre and post quasi-experimental comparing intervention and control. And so our outcomes, again, tended to be survey-based. And so this is Elizabeth Vandewater and Maliha Salahuddin who did the analysis for this part. And basically what we found is we didn't see any intervention control differences. Part of that we feel is because the intervention and the control, there was a base model of coordinated school health being done across the all the schools because it was required by law. So that was kind of hard. But what we did find is there were changes by implementation level. So the high implementation in most cases was related to better outcomes. So again, you kind of keep hearing this theme repeated. So then our secondary prevention, we worked with a program out of the UK called MEND. So how many of you here are familiar with MEND? Are any of y'all familiar with it? You are. So a few of y'all are. So we worked with MEND, but the physical activity part was then CATCH. And so this was essentially what we did. So we took kids, this was the intervention, and they were randomized after they saw the physician. So everybody got physician counseling at the beginning. And then they were randomized to usual care, and we had a self-paced booklet that they did. Or the Texas Cord Secondary Prevention, and then we measured several variables there. So in the secondary prevention, the kids who were preschool kids went to the MEND program, and it was one meeting a week for an hour and a half for 10 weeks, so roughly three months. And then they had a 9-month program where they came in once a month. With the preschool age kids, we did MEND CATCH, and we put them in 2 groups. Because one of the things we found is if you mix a 6-year-old with a 12-year-old, that's not a good thing in a physical activity program because someone ends up crying. So the 6-year-old wants to do what the 12-year-old is doing, but the 12-year-old will play too rough. So anyway, we did them differently to avoid that from happening. So we did 2 meetings a week for 10 weeks. So it's a really intensive intervention. And then we followed up with 9 months where they had to come in one time, and we went over the MEND lessons again, and we did cooking classes with them at that meeting. We also tried to get the kids into YMCA sports teams. So we did that in that 9-month period, and then we did text messages as well. So, and this was conducted in both English and Spanish because we had a large Spanish population. So this is Sarah Barlow and this is Stephen Pont. So they are the leads for this. And so, as I said at the beginning, the physicians were doing motivational interviewing with everyone who came through their offices. So they did that. They had next step charts. So these were these charts, and they were really cool because there was something that faced the patient, and then there was a crib sheet on the back for the physician. So they knew what to say. So it took very little training because then they could just follow the script. So these were actually very popular. They had these posters, and then they had, in the EHR, we had put prompts. So it would prompt them to check for height and weight. And then we used those for referrals as well. So then what they did is once they were referred to us for the intervention, we conducted that at the YMCA. And so we had theory leaders and then community health workers who were the liaisons with the families. So they would call the families, they'd check in on them, they'd have them kind of come to make sure that they came to all the sessions. So we did the preschool, as I said, and then the school-aged, and I described what those were. And then we also had Be Well Book, which are role model stories. So we had role model stories that we used with them as well. And there you can see them at the cooking classes. There was one of our theory leaders, and there's some of the kids doing the physical activity part. We had to redo the physical activity part because a lot of the kids were deconditioned. So you really had to be careful in terms of ramping up their physical activity. So here's Nancy Butte and Casey Duran. So they took the lead on this part of the project. And as you can see, the majority of our population was Hispanic. So really most of our classes were actually done in Spanish. If you can also look, these were Medicaid eligible families per the request for proposals. And most of them also had a very low education level. So it was really kind of, a lot of them too, I don't have the data here, but most of the parents were born outside of the United States. So in the range of about 65%. So these were our data. So if you look at them, we saw a time trend with the intervention group in 2 to 5-year-olds, but then they went back up during this transition period. They did go back up with the comparison group. There were no intervention comparison differences. With the 6 to 8-year-olds, we did see a significant intervention effect after 3 months, but not at the 12 months, so after the transition period. And then with the 9 to 12-year-olds, we did see a near significant intervention effect, but again, it didn't maintain over time. So we were kind of disappointed with this, so we looked a little bit closer at the data, because it's like, what do we do? So when you look at it, and again, I'm going to talk about dose. It's kind of a repeating theme here. But we looked at the intervention dose. So if you look at 2 to 5, 6 to 8, 9 to 12, the number of sessions they went to, and then the dosage in the percent, this was our comparison group. This was the intervention group. But if you look here, they really didn't have, we really didn't have very high dosage here. Even though we were calling them, we were located in the communities, it's just really hard given a lot of the parents were working 2 jobs, kids had extra tutoring, it was really hard to get them there. But when you look at our intensive sessions attended, and these were the 9 to 12-year-olds, we have these for all the grades, this was the percent difference between time 1 and time 2, 95th BMI percentile, which was our main outcome. If they went to 2 of the lessons, we saw a significant effect. So really the kids had to come to the lessons. The more lessons they came to, the greater the effect. This was during that first 3 months. We also looked at it the last 9 months. We didn't see that same pattern. So it's really important to kind of get them there. So we've been wanting to replicate this study, hasn't been funded yet, but really kind of looking at it where we can ramp up the implementation. And so we have a couple of ideas on how to do that. So this is just our study investigators, a lot of people involved with this study, and then the rest of our team with the school districts that helped and the clinics. So overall conclusions with CORD is primary prevention programs can decrease BMI over time with preschool kids and elementary school kids. So of all the things we did in this study, it looked like the primary prevention and the Head Start programs had the best outcomes. So implementation with the elementary school, that really played an effect on it, had an effect on it. And then with secondary prevention programs, it looks like they can decrease BMI modestly over 3 months. Past that, we probably need to look at different models. And then one of the things that we tried to do, it was very difficult for us to do primary and secondary prevention efforts in a large urban setting. So both Austin and Houston, that really got us, because we thought, oh, we'll go do this, and the kids that go to the Head Starts will go to the same federally qualified health clinics. Well, they didn't. The ones that were in the Head Start went to another FQHC, so we didn't get as much of that layering that we intended to have. It only was about 25%, either way you looked at it, that had both programs. So that was a little disappointing to us. So we really think doing this in a smaller area, you could really be more concentrated with the dose. So a couple of things that we're working on now that I think are really excited is with the primary prevention programs. Like I said, we're really trying to look at strategies to increase implementation. And then really trying to see how can we get programs in preschool. So y'all are doing that already, so kudos to y'all, because it really looks like there you can make a difference. And it seems like the parents are more receptive to what we've seen. So with secondary prevention programs, what we think is you need a closer tie to the medical home. So we're trying to figure out how to do this. When ACA was kind of moving forward and we had the prevention money, that was a little bit easier. Now we're seeing kind of drying up of those funds in the community. Y'all might have seen that too. But it's harder to do that right now, kind of in the current environment. We need a different approach for preschoolers. The parents don't see the preschoolers as being having overweight or having obesity. So it's hard to get them to come to a clinic program. We had trouble recruiting them as well. And we need to reduce barriers to attendance. And then one of the things we found out is our effects were actually better with kids who weren't as obese. So this program works a lot better if kids are not severely obese. So it's kind of like a stopgap. For kids who are very heavy, their moms were more likely to have obesity. We need to do something else with them, not this program. Okay, so these are what we're doing now. So I have a natural experiment that I'll tell you a little bit about, and then we're doing policy work with the Dell Center. And then this last project I'll just mention here is Co-Create, and we're using adolescents for policy impact. So it's a European Commission study, and I'm the US representative on there. I don't get paid though, because the European Commission doesn't think that you need to pay investigators in the United States. So we're trying to look for other money to kind of fund that here in the United States. So I have a grant out for that. But it's really cool. We're asking 16 to 18-year-olds what they think causes obesity. Then we're doing some systems level mapping, and then we'll be training them for advocacy, and then they'll meet, and we're kind of looking at them to negotiate with lawmakers and stakeholders after a while, and then they'll come up with some policy solutions, and we'll put them back in the system map and see if we see some changes. So it's a simulation study, because you can't implement policy and get outcomes in an NIH grant 5-year time period. But I thought y'all would like hearing about our street study. So street study is a 5-year natural experiment that's going to evaluate the City of Austin's Safe Routes to School program. So the City of Austin has allocated $27.5 million for Safe Routes to School. Just to let you know how much money this is, the state of Texas in 2007 allocated $28 million for the whole state. So what we had for the whole state, we've got in one city now. And this includes protected bike lanes, pedestrian islands, shared use paths, or pedestrian hybrid beacons. So it's a really cool study. We're working very closely with the City of Austin, and we're looking at population level changes in active commuting to school in the schools in Austin compared to some comparison schools. We're also looking at cohort level changes in physical activity and routes. So we're doing surveys with kids and their parents and following them for 3 years. And we've got accelerometers and GPS units on them too. So we're going to see if their routes change because of changes in the environment. And then we're evaluating the cost effectiveness of changes. So we know how much money was put into each school, so we're able to look at that. So we're recruiting right now because the release of this program it's a stepwise fashion. And so we're recruiting on a rolling basis. But we're doing this active commuting to schools, and we were going to recruit 100 schools, and we've got 90 right now. So I'm real happy. That's a lot of schools. But we're real happy with what our team has been doing. It's a little bit more challenge to recruit them for this cohort level study. So the other thing we're doing is we were funded this last go round. We're funded every 4 years on our center. And so we were funded, they want us to really be strategic about communication of our research. So they really want us to reach stakeholders and policymakers. So we are developing a lot of child health status reports using our F.I.S.B.N.P.A data. So we are going into the field in 2019, 2020, so we'll have a 5th data point, which I'm so excited because we can do some really cool trend analyses after that. But we've also done an interactive SPAN website, so it's not, it's very serviceable. It does what it needs to do. I'd like for it to have more bells and whistles, but this is phase 1, SPAN Interactive 1.0. And then we have an advisory committee. And so along with that, we're developing toolkits that will be on our website that parents can use. And what parents are telling us is they want toolkits. We thought it was going to be obesity prevention, or how to do healthy eating and physical activity in their home. What they want is they want us to tell them how to advocate for these kind of programs, which I thought was really interesting. That was not what we thought they would say. And then we're doing dissemination, and this is like my favorite part of the new scope of work. So we're working with a marketing company, and the marketing company is going to create like 5 to 10 slogans for us to use to kind of make parents be a kind of a call to action for obesity prevention. So it's something like, and I don't think this is going to be one, but it's like, let's nourish our kids, not just feed them. You know, so it gives a certain connotation. So they've gone through the first round of focus groups, and they're developing our messages right now, and we're going to test them with focus groups on people across Texas. And so they have an online system that they do with marketing a lot of other projects, and we get to sit like in a back room. So it's like a Zoom or a WebEx or something like that, and we get to watch the focus groups. So we'll be able to see people's reaction to these different themes and what they think. So it's really nice. We're getting a wide swath of Texas with this. So it's more than the usual people we talk to. So I'm really excited to see what those messages are going to be. And then we're going to use them heavily in our interventions, in our promotional materials. And so these are our one-pagers that I described. They're for legislators. So there's a lot of white space here. And then on the back, we've got a lot of references that talk about what's going on. And then this is our interactive SPAN database. So you can decide, do you want statewide or health service region, how you want them grouped, which grade, and then here it's the whole sample boys and girls. So you can look at the distributions. So it's been pretty fun to play with this, and we've had a few groups write articles off of this for the media. So we really think it's getting to where it needs to go. We're going to be adding all levels of, all years of SPAN, but we kind of ran out of money after this, so now we're going to do that. And then this is something else we're doing with SPAN. So this was a paper that was published this year. So what we did was we looked at days of more than 30 minutes of physical activity and then a physical activity policy score. So when we did SPAN, we do a school level survey and we ask them how many policies and programs they have in place, and we developed a scoring system. So this is standardized here, and what we looked at were high income schools, medium income, and low income schools. So our low income schools I think are real close to what y'all's are. So they're like maybe a median of 90, 95% economically disadvantaged, so kind of in that same ballpark as y'all. But if you look the high and medium income, you really didn't see the effect of the policies. Where you saw the policies were in the low income schools. So it's really important when you're looking at these policies to really focus on lower income schools, because that's where you can make the most difference. And then finally, our last thing is we're developing a network linking policymakers to researchers in Texas. So what we're going to do is take 10 policymakers in Texas, and we'll pair them with a researcher. Hopefully, if it's someone from Lubbock, for example, we'll pair them with someone from Texas Tech. So it's someone that's a constituent. And then what we're going to do is provide them support so that they can provide advice to the legislator. So we're going to do a matchmaking service. We're going to train the researchers. You don't want to talk to a policymaker and say, we need to do more research. You know, you need to be pretty definitive about what you say. So we're really excited about this too. We're getting to the point where we're about to pick our legislators. It's hard for us because our legislature only meets every other year, which is kind of crazy for a state as large as Texas. So we'll be implementing this next year and for the 2021 session. And then finally, I always like to end with this quote because I think the test of the morality of a society is what it does for its children. So I really think it's important to start with a healthy environment, healthy programming for children, and that's really an emphasis of our center. And so I just want to applaud y'all for the good work you're doing here, because obviously a lot of you espouse this as well. Not that you don't need health throughout the rest of your life, but I think that this is important for us to look at. And especially when you realize how quickly kids grow. This is my son, who is now a freshman at college. So it doesn't seem like so long ago that he was a round-headed little baby. So thank you very much.